Assalamu alaikum everyone and welcome back. Before we start, I want to say a huge thank you to all of you. It's been, I guess, more than 2 months since my last upload. And despite that, many of you continued reaching out, requesting new guidelines updates and sharing how helpful these short videos have been for your exam preparation. Well, your support and appreciation genuinely motivated me to keep creating evidence based content. After a short break due to some personal commitments, I am delighted to be back. And today we are going to review one of the most important updates in obstetrics, that is the RCOG Reduced Fetal Movements Guideline 2026. And now we are going to see how exactly and what has changed and why it matters for our daily clinical practice. The 2026 guideline is not simply a revision of the old document. It introduces several important changes that every obstetrician should know. The biggest strength of the new guideline is that it is more evidence-based, more patient-centered, more inclusive, and more focuses on the prevention of stillbirth. Now let's see some major differences between old 2011 guideline versus new 2026 guideline. The first major update is that the new guideline links reduced fetal movement much more strongly with adverse pregnancy outcomes, while the 2011 guideline considered it simply a warning sign, as you can see here. The 2026 guideline emphasizes its association with stillbirth, placental insufficiency, fetal growth restriction, small for gestational age babies, and also congenital anomalies. Well, in fact, the risk of stillbirth is reported to be about 3.4 times higher in women presenting with reduced fetal movement. This highlights the importance of prompt assessment and timely intervention. The second major update, and perhaps one of the most interesting additions in the 2026 guideline, is the recognition of sudden, excessive, vigorous fetal movement as a potential warning sign. Traditionally, both clinician and pregnant women were taught to focus mainly on reduced or absent fetal movement. However, the new guideline advises women to seek medical attention not only for decreased or absent fetal movement but also for episodes of sudden, unusually vigorous activity, especially when these are followed by a reduction in fetal movements. So this recommendation is based on observations from some stillbirth cases where mothers reported frantic type of movement, repeated powerful kicks, or unusual fetal activity before fetal demise. So many women still believe this is sort of a myth. So myth about strong movement that usually women consider that strong movement mean baby is definitely fine. But normal strong movement are generally reassuring. The new guideline highlights that a sudden and unusual increase in the intensity of movement may also require attention. So please note this key point, that simply whether the baby is moving strongly or weakly, but attention is to be given whether there has been a significant change from the baby usual pattern. Therefore, any sudden violent or frantic activity followed by reduced movement should prompt immediate assessment. So, we have to remove the myth that women usually believe. Now, the third major update relates to fetal movement monitoring. The previous 2011 guidelines stated that there was insufficient evidence to support formal kick counting, and refer to the commonly used targeted of 10 movements within 2 hours. The 2026 guideline moves even further away from rigid counting method. Instead of focusing on a specific number of kicks, the emphasis is now on understanding each baby's individual movement pattern. The guideline recognizes that there is no universal normal number of movements and that the quality, strength, and pattern of movements may be more important than simply counting kicks. It also introduces the concept of mind-fetalness method. Please note this terminology. And maternal awareness as modern approaches to fetal movement monitoring. So, in this third update, the modern approaches to fetal movement monitoring includes spatially mind-fetalness method and maternal awareness. Now, let's see what are these. In practical terms, mind-fetalness involves taking a few quiet minutes each day to pay attention to how the baby usually moves. Rather than asking mother to count 10 kicks, it encourages them to notice the strength of movement. Please note the rhythm and pattern of activity, the frequency of movement, as well as stretching, rolling, and other characteristic behavior. This awareness-based approach helps mothers develop a better understanding of their baby's normal activity, and this may also improve early recognition of potential problem. So the new approach is not about counting exact kick, it is about understanding your own baby's normal movement pattern because every baby is different. And recognizing change from baby's usual pattern is more important than reaching a specific kick count. Okay? So for exam purpose, remember one sentence. The 2026 RCOG guideline emphasizes maternal awareness of baby's normal movement pattern rather than formal kick counting. Now, the fourth major update addresses one of the most common misconceptions in pregnancy. Many women believe in 2011 especially that babies naturally move less near term because there is less space available in the uterus. The 2011 guideline mentioned that fetal movement tend to plateau after around 32 weeks. However, the 2026 guideline uses much stronger wording. It clearly states that while fetal movements may change in character as pregnancy advances, they should not decrease in frequency or strength during the third trimester. This is an important distinction that clinicians should emphasize during antenatal counseling. So for exam and clinical practice, remember this sentence. Movement may change in nature, but they should not decrease in frequency or strength. Another important feature of 2026 guideline is its strong focus on patient education. Women are encouraged to understand their baby's normal movement pattern, report concerns promptly, and avoid delaying medical assessment. The guideline notes that many women postpone seeking help because they are reassured by relatives, worry about being ignored, or fear medical intervention. So the key message is simple. If your baby's movement feel different, trust your instincts and seek medical advice because it is always better to be assessed than to wait and worry. So never ignore your instinct if baby movement feel different. Remember one thing also. When it comes to fetal movement, mothers are often the first monitor of fetal well-being. The sixth update is much clearer regarding obesity and anterior placenta. Although these factors may affect how fetal movements are perceived, they should never be used as reason to dismiss a woman's concern. Because the 2026 guidelines specifically states that reduced fetal movement must be assessed appropriately regardless of maternal BMI or placental location. So this update is also clinically important. Well, another notable change in the 2026 guideline is the use of more inclusive and modern language. Unlike 2011 guideline, which used traditional terminology, the updated version specifically acknowledges women, transgender people, and non-binary individuals. This reflects a broader commitment to patient-centered and inclusive healthcare. Unlike the 2111 guideline, the 2026 version includes recommendations for twin and multiple pregnancies as well. Women presenting with reduced fetal movement should undergo appropriate fetal surveillance, including CTG, growth assessment, Likert assessment, and Doppler evaluation as well. Unlike 2011 guideline, the 2026 version provides separate management pathways for pregnancies before 24 weeks, between 24 and 28 weeks, as well as after 28 weeks, making the assessment of reduced fetal movements much more structured. Now let's discuss the most important part of this 2026 guideline, that is management of reduced fetal movement by gestation. Before 24 weeks, management is relatively straightforward. The main recommendation is to confirm fetal viability by documenting the fetal heartbeat with a handheld Doppler. CTG is not useful at this gestation and fetal movement may still be irregular. So for MRCOG and FCPS exam, remember, before 24 weeks, think viability first, not CTG. As pregnancy progresses beyond 24 weeks, assessment becomes more detailed and includes evaluation of maternal risk factors and fetal well-being. Now, between 24 and 28 weeks, assessment becomes more comprehensive. In addition to confirming the fetal heartbeat, clinicians should evaluate risk factors for fetal growth restriction and stillbirth. Measure maternal blood pressure, check urine proteins, and assess any concern regarding fetal growth. Routine CTG is not strongly recommended before 26 weeks because the fetal autonomic nervous system is still immature, making interpretation difficult. Therefore, the focus remains on viability assessment and clinical evaluation. So remember, between 24 and 28 weeks, Doppler, risk assessment, blood pressure, and urine protein. Routine CTG before 26 weeks is generally not recommended. After 28 weeks, management becomes much more active. Assessment includes confirmation of the fetal heart, computerized CTG, and ultrasound when indicated. Ultrasound should assess fetal growth, amniotic fluid volume, umbilical artery Doppler, and evidence of fetal growth restriction. If all investigations are reassuring, the woman can generally be reassured and routine induction is not required. However, if abnormalities are identified, clinicians should evaluate for fetal compromise, placental insufficiency, fetal growth restriction, and the possible need for urgent delivery. To summarize, before 24 weeks, confirm the fetal heartbeat only. Between 24 and 28 weeks, perform risk assessment, Doppler, blood pressure measurement, and urine protein assessment. And after 28 weeks, we have to do computerized CTG, ultrasound assessment, and Doppler because these becomes the key investigations. The 2026 guidelines specifically mentions computerized CTG rather than simple CTG, reflecting modern fetal monitoring practices and more standardized assessment of fetal well-being. A key message from the 2026 guideline is that normal investigation do not automatically mean induction is required. If CTG growth, Leica, and Doppler assessment are reassuring, expedite birth is usually not indicated, although delivery may be considered after 39 weeks. But before 39 weeks, if everything is reassuring, then there is no need to do unnecessary inductions. However, one thing should be noted in this 2026 guideline that if reduced fetal movements occur repeatedly, reassess every time. The 2026 guideline emphasizes that recurrent episodes should not be dismissed and should trigger further evaluation for possible fetal compromise or placental insufficiency. Now, this algorithm outlines the management of reduced fetal movement after 28 weeks. The pathway starts with a detailed history and assessment of risk factor. If reduced fetal movements are confirmed, fetal viability is established, followed by a computerized CTG. Abnormal findings require further management, while persistent symptoms or risk factor warrant ultrasound assessment, including growth, Leica volume, and Doppler studies. If all investigations are normal, the woman can be reassured, but should not be advised to seek review, but should be advised to seek review again if symptoms recur. So for exam, remember the pathway in 4 simple steps: history, heartbeat, CTG, and ultrasound. That is history, heartbeat, CTG, and then we have to do the ultrasound. So before I end, I would like to thank all of you for your continued support and encouraging messages, especially during my recent break from YouTube. Your appreciation of these short guideline reviews motivated me to keep creating more content. So if this video was helpful, please like, comment, and subscribe. Let me know which guideline or topic you would like me to cover next. Until then, stay updated, keep learning, and remember, every movement matters. And Allah Hafiz.